The next part is controlling glycemic variability with exercise in the type 2 diabetics. Ooh, we skipped a bunch here. What is going on? Okay. Here we go. So diabetes can be stopped with intensive lifestyle change. I really like this. It's a Finnish diabetes prevention study. They had 500 middle-aged overweight patients with impaired fasting glucose. And they put them either into usual care, which is, I don't know what, or intensive lifestyle change. So they hired personal trainers. They got these guys in a program. And what they found, lo and behold, is that they got better. The diabetes reversed. But the catch was the moment they stopped this intensive and expensive personal trainer, they went back to old lifestyle habits.
No
And
way.
yeah, they did, unfortunately. And that's actually reality. So I really like when studies are like real life too. So this is amazing. This is so cool. But what was happening here? So let's talk a little bit about the exercise science behind this, because I love explaining this to patients every day. You got muscle, right? As I tell patients, you want to grow your muscle as strong as possible. You want as many muscle fibers, you want them as dense and as big as possible. Why do you want this? Well, it allows you to tolerate carbohydrates better. Your body
Bingo.
knows what to do with a carb. It puts it right into the muscle as a storage form, glycogen, right? So that the next time you go train, because your body learns over time that you're a crazy person who goes and trains intensely every day. The body knows that it has to store the glucose in the muscle as glycogen. So the next time you train, it releases glucose. It breaks down glycogen. Boom, glucose comes and it keeps your blood sugar up. You don't get fatigued and dizzy and so forth. Now, as prescribers, we have to be aware when we put patients on these medications that affect their glucose metabolism abnormally, when we give them a carbos that literally it inhibits the absorption of carbohydrates, well, these patients, they may have some struggles with the training program. They may get weak and dizzy when they're playing tennis, which I saw this recently on a tennis court, a lady diabetic on metformin, passing out almost on a tennis court. So they have impaired glucose metabolism and storage because they're on medicines, but they also have impaired glucose metabolism storage because they're diabetics too, with a low muscle mass and the sarcopenia. So it's a challenge.
Stefan, one thing to add there, when you mentioned metformin in these patients, let's let it be known that when these patients use metformin and they combine that with anaerobic activity, the mTOR blocking effects of the metformin will blunt the positive effects from the exercise.
Yeah. It's touted as an anti-aging drug, this metformin, but I counsel my friends in anti-aging medicine that muscle is the most important anti-aging tool we have, not metformin.
And that is the TAME study that is currently underway to evaluate if metformin is anti-aging in non-diabetic patients.
Well, that you're talking about high dose of metformin, but when you go to 100 milligram of weight loss dose, I don't think it will have that.
100 mg is probably not gonna.
Yeah, I'm talking about 100 meg, and then we add B12 there because metforming does cause malabsorption of B12. So it's not that big. Yeah, if somebody's taking 500, 1,000 milligram, then I agree with you. You know, you want to consider all those side effects, but 100 milligram, it's not a big deal.
Fair enough.
Right, fair enough. This study, for our people who like mechanism, very cool. What they did is they got rid of the gene in these poor mice that allowed them to store glycogen in the muscle. And so these mice that were missing this gene of glycogen storage, they all became insulin resistant very quickly. So this is a cool little mechanism for all of us to understand that you want your patients to be able to store glycogen in the muscle. The moment they don't do this, which is most of our population, I'd say 92% of our patients have low muscle mass, high fat predominance. They don't train. They don't know how to lift weights. They do not know how to store carbohydrates correctly. So when they're eating standard American diet, 60% at least carbohydrate, they're not storing this correctly. They're all insulin resistant. And this causes them to have the obesity, poor fat storage, the metabolic syndrome, you name it. This is a cool little intervention. You can tell your patients, old or young, they can do a walk afterwards, right? Even a walk after a meal can blunt postprandial glucose excursions. This is for diabetics on the metformin monotherapy. Just have them walk after a meal, especially after breakfast, if they're eating the SAD. This is caloric restriction plus exercise on insulin resistance and cardiometabolic risk factors. And lo and behold, exercise plus caloric restriction was the best way at reversing this metabolic syndrome. But exercise even alone can be an effective non-pharmacological treatment strategy for insulin resistance, metabolic syndrome, and cardiovascular disease risk factors in older obese adults. They don't always need to caloric restrict, just get them to train more, and they're going to get better. So they did specifically walking on a treadmill or a cycle, starting at 60% of their heart rate max and increasing it over the weeks to 80 to 85% over 12 weeks. So this was progressive overload study. So I'm going to look at some of my CGM data because it was very interesting and it kind of highlights glycogen. And so it kind of give you an idea of what it looks like when I play tennis, to give you an idea of what's going on here. So I play at a pretty high level, high intensity. So when I play tennis, my blood sugar goes up. Here it showed it went up to about 130 milligrams per deciliter. Very interesting, right? Like, wow, why is his blood sugar going up so high in a tennis match? And I'm sure you guys know the answer to that, but I query my patients this routinely to see if they can start thinking about this. Here, I also go out to eat. I had a night out, Turkish food. It was like breads, ice cream. I only went up to 117 milligrams per deciliter. I even had a cocktails. So you can see that a tennis match increases my glucose more so than a night out in the town. Now, why might this be? I'll give you guys the answer. It's because my body is releasing glycogen storage or releasing glucose from storage form of glycogen in my muscle, and my blood sugar is increasing to keep me sustained throughout a match. My body knows that I'm a crazy person who will play 3-set matches in tennis tournaments and that it needs to store carbohydrates when it gets the chance. So I have very good storage. So this allows me to go out and not be so careful with what I eat sometimes because my body knows how to handle it, right? And so this is my insulin levels, 2.1, as low as 1.1 I've seen, which is quite extraordinary. I usually have them around 2 or 2.5 insulin levels. Very low insulin after 8 to 12 hour fast. There's another concept here to think about. BMI measurements give a false sense of health. This is type 2 diabetics. They did 16 weeks of progressive resistance training, supervised. They had a trainer, and they all lowered their visceral and subcutaneous abdominal fat by about 10%. There was no change in body mass in all these patients. So keep that in mind, that visceral fat is another marker sometimes look at in these folks. It's a predictor of all-cause mortality in men. Higher visceral fat is associated with heart disease and stroke. Again, it's not always about the A1C, and it's not always about the fasting blood sugar. They're not so helpful always. We've got to look at these other markers. CGMs, get them on a CGM, have them measure their visceral fat. This is hypoglycemia post-tennis match. So my blood sugar after a match, it will drop down to 73. I see this pretty routinely because my body gets pretty depleted. So this is what you can see in glycemic variability in an athlete. And I don't consider this pathological. I consider this normal athlete response.
Are you feeling symptoms at 70 for your blood sugar?
No, I feel absolutely nothing.
I was about to say, yeah. I mean, because that's where normally mine's in the 60s, highest it gets is the 70s. And I never feel any symptoms.
Have you worn CGMs?
No, I have not, but I think I might just for fun, just for a fun study.
Oh yeah, it's just for fun, just to see what's happening in our body.
Yeah, I will just for a fun study. But that's really, yeah, okay.
I learned this about myself. When I get into my Morosco at 36 degrees Fahrenheit, my blood sugar will drop to about 69 milligrams per deciliter. And this was consistent. I did this daily, and every time it would drop super low. And sometimes my CGM would scream at me, go beep, 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 send off an alarm. Look, your blood sugar is low. Like I felt nothing. It's just something was happening in the Morosco, in that cold exposure to lower my blood sugar. So this is a 3 times a week randomized trial of resistance training in controlling glycemia in the type 2 diabetes in older adults. They were able to reduce their prescription of diabetes medications by 72% in those who started lifting weights compared to the control groups. This is how powerful growing muscle is to reversing the diabetes in these patients. Here's another one, twice weekly resistance training. The visceral and subcutaneous fat reduced by 10%, but no observed changes in body mass. I oftentimes have to tell my patients this, even back when I was a trainer. So this is a case of a trainer. I was working with a 56-year-old African-American female diabetic, 315 pounds, osteoarthritis, both knees. She couldn't do much. So this was back when I was a young personal trainer, fresh out of school. And I had to work with this lady. And I worked with her for months on end and figuring out what she could and couldn't do. And she came to me one day and she said, my doctor said, what are you doing? And she said, well, what do you mean what I'm doing? He says, your A1C is improved. And she's like, well, I got a personal trainer. And he's like, keep him. He's doing good work. You're getting better here. And she had been stable A1C of 7 or something crazy. And they call that stable, but for years. But her A1C was finally moving in the right direction after doing this progressive resistance training with me at least twice a week. This is interesting. Normal exercise, even with caloric surplus. So the healthy individuals on a high caloric intake were randomized to 10,000 or 1,500 steps a day for 14 days. And surely nothing could happen in 14 days, right? False. Both study groups gained the same amount of body weight. However, the inactive group accumulated significantly more visceral fat compared to the active group. So this is empowering for you to tell your patients. You say, hey, I have a study that shows if you actually start moving around 10,000 steps a day, you actually start losing some visceral fat. The effect of acute exercise on endothelial function following a high-fat meal. This is interesting because there's often recommendations to do low-fat diets because the ADA says that high-fat diets are contraindicated in diabetics, even though we know that ketogenic diets will help control their blood sugars, as we'll see later. But a simple bout of aerobic exercise can not only counteract the postprandial endothelial dysfunction induced by the ingestion of a high-fat meal, but it also increases brachial artery in apparently healthy adults. So very cool. We won't go too much into this. I've given a previous lecture on how to build progressive resistance training program, but I would tell you that you have to get your patients to hire a personal trainer. They won't want to fork out the dough, but as we see both in the literature and if you know how patients are in practice, they need someone to observe them and to keep them accountable. And you have to put into perspective for them that an amputation of your foot because of diabetes is way more expensive than anything a personal trainer could ever cost you. So get them to hire someone and keep them accountable. Tell them that they will be sore. To avoid NSAIDs use, you'll catch patients think they're clever and they'll start popping ibuprofens before a workout. This inhibits muscle synthesis. Oh yeah, the patients do crazy stuff like that.
Oof.
No.
Oh, bad idea. Really?
Yeah,
bad
no.
idea.
I had this one patient. He was so proud. He said, I take an ibuprofen 400 milligrams before I work out and I never get sore.
Oh,
Yeah.
You need that inflammation for the tearing of the fibers. And if you block that, then you're going to have it's not going to be good for resistance training. So yeah, that's a big no-no.
I'll tell you that. Go ahead.
Go ahead.
What about America?
I was going to mention that I did a study unpublished. We did a placebo controlled double-blind crossover in elite. What's the name? The type of exercise. Sorry, I'm blanking on it. But these guys they can measure their energy output. CrossFit. And of 5 of the 9, one didn't complete the surveys, but of the 4-week trial where we used 20 milligrams of CBD 1 hour before starting training and immediately following training, 4 of the 8 that completed it
had a significant noticeable improvement in both recovery and energy output. But it wasn't, the numbers weren't strong enough to warrant publishing it. Anyway, have you guys noticed that at all? I know Dustin is on the call. Have you seen that with any of your cannabis athletes?
I can't see what mechanism there would be to do that, but that's very interesting.
Curious.
Well, it lowers inflammation through a number of pathways, but that was, at least for the gym owner, which was performing at an elite level. She had been taking a sublingual oil, a CBD oil, around 25 to 30 milligrams, and she replaced it with 20 milligrams of a troche, and had a noticeable improvement in both her recovery time and her energy output.
Sorry, I'm muted. Okay, so yeah, just briefly, there's been a handful of survey studies looking at athletes and their cannabis use, and a lot of them like to use it before training because they think it kind of enhances their performance. And just anecdotally, people talk about the mind-muscle connection going deeper. They can push deeper
Okay,
into
fair enough.
failure.
That makes sense.
And then people also report better recovery after training, probably because of the analgesic, but maybe, you know, similar to the NSAIDs, maybe they're blunting the actual growth to some extent in exchange for this, you know, kind of deeper mind connection and less soreness. It's possible. You know, a lot of the cannabinoids have some COX inhibition activity and then other anti-inflammatory mechanisms.
But you're saying a possible nootropic effect?
A possible neurotropic effect?
Yeah.
Yeah, well, I think, you know, whether it's directly acting on the nerves, which, you know, the cannabinoids do have this neuroplastic, you know, component, and certainly not just exogenous ones, right? Like our endocannabinoids, we're currently using those at the same time. But there's so many negative feedback loops, you know, like you get a big blast of endocannabinoid production with the cold exposure too, or at least in rodent studies they do. And that's like the negative feedback signal from the peripheral tissues to the sympathetic nerve endings saying, stop sending norepinephrine, right? So like, you know, that there's going to be, it's just so complex. It's hard to say, but I do suspect that cannabis could be blunting some of the growth due to the anti-inflammatory
I would
effects.
suspect, I would concur with that. I would agree with you on that.
Yeah, I agree too. And that's why I don't recommend my patients use the cold forage after a workout. I say you do it before a workout because it'll give you that adrenaline, dopamine, cortisol boost. You could hit the workout hard because one, muscle likes to work out colder. It doesn't like to be hot. You don't go into the sauna before you work out. Cold workout, and then usually finish with the sauna is my recommendation.
Sounds great. Well, I wonder with the cold plunge, like how long those anti-inflammatory effects are lasting. You know, is it just a couple hours, or could it be longer?
I think it's pretty transient. I don't get in there that long. I'm in there like 40 seconds. I use it mostly as a pre-workout.
Got it.
Yeah.
Probably
I
not
remember
getting
you telling me that, Stefan. I think it's pretty transient too.
Yeah. And some people will chill in there for like 5 minutes. I think when you get like that, you're working on anti-inflammatory effects. People use it for arthritis at my clinic.
Hey, Stefan.
Yeah.
Hey, great lecture, by the way. You're getting good at this.
I second that. It is a good lecture.
Right.
Keep going.
But I did have a question. So have you come across patients who, since COVID, maybe they've developed sort of like a mast cell activation syndrome, such that when they try to work out, they get inflamed, and so that leads to excessive fatigue, and so there's like this balance.
I know exactly what you're talking about. So you're one of those patients. You have a mitochondrial problem, right?
I mean, I've got basically a toxic load that I've been working on. You know, epigenetically, I have a detoxification I would say, challenge, which I'm addressing better and getting more, I would say, more optimized, more precise with my optimization. And I am exercising better, but I've always been an athlete, but the challenges that I went through were beyond what I had ever experienced. So, like I said before, I had a breakthrough about a year and a half ago where I went from running 4 blocks to running up to 4 miles without
Yes.
stopping, which was a great.
I remember that. You told me that. Yeah, and it seems like you use some sort of mitochondrial enhancer. But if you want to talk about from a cold perspective, see, when the patients that got mitochondrial disease, their mitochondria heat up too much. So they'll get up to like 130 degrees Fahrenheit. And then when they get too hot, they don't perform very well. So you will have very low exercise tolerance. You'll get a block. You'll be gassed. You'll feel terrible. You put a patient with mitochondrial disease in the cold forge at 30 to 36 degrees Fahrenheit, they'll feel fantastic and they'll have much better exercise tolerance.
Okay, no, that's great. So you can do a cold plunge and you can go straight to exercise, and then that's what I'm understanding from what you're saying. And then I was also going to try also, in addition, the I guess you could say it's the mitochondrial focused supplement that Dr. Beamer is putting out. And I was going to comment on the weight loss supplement as well, that it will be interesting to see because I have done activated charcoal, but in higher doses when I was really trying to flush mycotoxins out of my digestive tract. But